Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a simulation case about a patient who is coming with narrow complex tachycardia.
So here we have a patient who was brought to ER with acute onset of palpitation since last half an hour. Okay, he is stable now, but we have taken him inside the ER. We are kept on the bed. We are taking care before taking care his airway. We are connected to the monitor. We'll see what are the findings in this ECG. His heart rate is 180. You can see the rhythm and rate of this patient in monitor. His saturation is 99 and BP is 129/79. So this patient has come with palpitation since last half an hour. He never had the same history and he never had hypertension in the past. He had consumed alcohol yesterday night.
Okay, sir. So coming to the normal survey, initial assessment is over as patient has been
kept on the bed.
And airway
is stable at present. There is no pulling of secretion, gurgling sound. Saturation is maintained.
And breathing part
is stable.
Normal.
He is only anxious.
And otherwise in circulation part also
heart rate is very high. That's all. You can see the monitor. You can analyze the rhythm and whatever treatment is
required. Sir, comorbidity, sir? There
is no comorbidity. He is a young male without any previous history of any illness.
So when we are checking the monitor, we can see that we are having a regular narrow complex tachycardia with absent P waves. Can I see the ECG?
ECG shows narrow complex regular rhythm and there is no ischemic change.
No ischemic changes. So sir, the most likely chance the ECG showing the diagnosis is SVT.
Okay.
For SVT, so as the patient is stable, we can go for initial management including the carotid massage or Valsalva maneuver.
You can start the management according to your plan.
So for carotid massage, the main thing is carotid massage. We are doing the carotid massage in the carotid area between the angle of mandible and the tracheoid cartilage in between. So for massaging, initially we had to rule out carotid bruit. So we had to look at whether there is any carotid bruit.
There is
no carotid bruit. So for carotid massage, we will be massaging at the carotid area for 5 seconds.
We'll see. Is there any change?
Carotid massage done.
There is no change in the monitor. Heart rate is still high. 181 is the heart rate.
So if the carotid massage is a failure, we will go to the next line of management, that is giving adenosine. So
your technician is ready.
Yeah. So for adenosine, we have to get a IV line placed. Can you place IV line?
So she has put an IV line.
So most better to have proximal or proximal left side or proximal to heart. If at all we are giving to the hand, initially we will give 6 mg adenosine followed by rapid flush of 29 ml normal saline, and we have to raise the hand following the adenosine.
So you have given adenosine. What you have to do now?
Flush and raise the hand.
You flush this one and raise the hand. Okay. Now we'll see. He has given adenosine. We'll wait. Okay. Now the heart rate has come down to normal. It's coming back to normal. Okay. Now it is completely come back to normal sinus rhythm. It's a narrow complex sinus rhythm with heart rate somewhere around 58. There is no desaturation after adenosine. Everything is looks normal right now. Suppose the patient does not come back to normal after first dose of adenosine, what will you do?
So we have to give the second dose of adenosine, double the dose, and we will give adenosine as 12 mg for rapid flush, and again we will raise the hand.
If you put a center line?
We can give half the dose
of the recommended dose from the periphery is required for this. Okay. Is there any contraindication for adenosine? So
adenosine as such can cause hypertension, and also in cases of comorbidities like bronchial asthma, patient can have bronchospasm.
Okay. Is the rate is still same?
So right now
is normal. Suppose the patient does not improve with your second dose of adenosine, what is the next choice?
So we can try with beta blockades if the patient is not having any comorbidities, and we can also try with amiodarone also.
Amiodarone also. Okay. So beta blockers, what beta blocker you give?
We can try with metoprolol,
Okay.
diltiazem, verapamil also has calcium
Okay.
channel blockers.
Okay. Okay. So what is the action of beta blocker in the heart?
So we are actually reducing the heart rate. Beta blocker means beta 1 heart rate is reduced.
At least the conduction from SI
Conduction
node to AV node will be reduced. Which all conditions you cannot give beta blocker or calcium channel blocker?
In cases of like bronchial asthma,
Bronchial asthma, beta blockers are relatively contraindicated.
Then
In SVT, where will you avoid beta blockers?
hyperthyroidism.
Where will you avoid beta blockers and calcium channel blockers?
Where
It's
patient is
SVT, no? There is no block.
um,
If it is a wide complex rhythm, then if you are not confident about what is the reason for wide complex rhythm, like Wolff-Parkinson-White syndrome, then you better avoid it.
beta blockers.
Okay. There you can, as a first choice itself, you can use for
Amiodarone.
amiodarone. Okay. Now what is the rhythm?
Sir, now also the rhythm is changing, sir.
Okay.
Patient is having again. Patient is having
No, pulse
reappearance
is
of SVT.
slightly feeble now. The heart rate has increased. Uh, it has come back to your old rhythm, narrow complex regular tachycardia. But the only problem here is now BP is low, 79, 59. Pulse is very feeble. Saturation is stable.
Saturation
Is
stable.
okay. So what to do now?
So as the patient is having a hypotension, so the patient is directly coming into unstable category, whereas hypotension, cardiac failure, or a shock or any altered mental status are the features of unstable patient. So as patient is unstable with a narrow complex regular tachycardia, so we can go with the synchronized cardioversion.
So you can.
So can you connect the patient with the monitors and a defibrillator, and
you can connect the patient to the monitor.
So for prior to the synchronized cardioversion, we have to get the consent from the bystanders.
Consent is already taken.
Patient can go into assistole also as we are having cardioversion, and we'll sedate the patient before having the cardioversion.
Okay.
And
so we are connecting to cardiac monitor before shocking. Defibrillator we are connected. Okay. So what to do now?
So synchronized cardioversion means we will be syncing with the patient heart rate with the defibrillator, and we will be giving
press the
shock.
synchronize button.
So we will be giving a joules of nearly for the new recommendations guidelines give 50 joules initially, and we can double up the doses if at all the patient is not coming not having is not reverting. So for cardioversion, everyone other than the charger should be cleared, and the patient, the one who is giving also should be cleared. All clear, I clear, charge.
Okay, shock is delivered. It is coming back to normal. Okay, now it is completely come back to normal. We don't know what is the reason for SVT. Now what we can continue for this patient?
So post adenosine patient.
Adenosine, you became unstable. You are given shock. What else you can start now to prevent further episodes of SVT?
So we can start him on beta blockers.
Either you can start beta blocker or you can start diltiazem, or better choice will be amiodarone because he has gone to unstable rhythm once. It will be better to start amiodarone infusion as a first line therapy here, and it can continue, and he may have to take that for some more time. Okay. Meanwhile, you want to do any other investigation in this patient?
So we can send for TSH thyroid test.
Thyroid function test can be done because hyperthyroidism is one of the reason for tachyarrhythmia. Then
we can do an echo.
Echo is done for what?
Ischemic heart disease.
Ischemic heart disease echo will not be helpful.
Then in any RWMA changes are present.
Okay, any valvular heart disease or ischemic not ischemic changes, like you told, regional wall motion abnormalities, all these things can be checked. Any other things you want to check?
Mm.
Huh? You want to do a cardiac enzyme?
No, sir.
Why?
Post shock cardiac enzyme.
So if you want to send a cardiac enzyme, you should have sent before the shock. Now problem is it will be elevated. So it may not be very useful, but if you can do it before that, you have to do it. Okay. Then what else you can do?
Post cardioversion, you have to get an ECG again, and
ECG, what changes can happen in post cardiac shock? You are given a shock. Any changes can happen in ECG. Most of the time, it will come back to revert to normal. Any other changes can happen after DC cardioversion or cardiac massage, repeated cardioversion, cardiac massage. Sometimes there can be pericarditis. Okay, so that we know. So even if it is there, there is no issue. Okay, so basically we have to do some investigation like that. Now this patient will be admitted to your ICU for at least 24-hour monitoring. What else you have to give for this patient?
um, post patient can have again, there is high chance that patient can again go into SVT. So we have to keep a monitoring of the patient, and also we can start him on amiodarone tablets,
Amiodarone can be given as tablet.
infusion and post
So whenever
tablets.
you get a supraventricular tachycardia in your emergency room, basically what all things you have to do?
So
if a patient who come to emergency room with supraventricular tachycardia, how is the rhythm in supraventricular tachycardia? According to ACLS protocol, what is the rhythm? Narrow complex, regular rhythm. If it is narrow complex, irregular rhythm, it is mostly atrial fibrillation. If it is wide complex regular rhythm, regular rhythm, what are the problems you can have?
so
Wide complex regular tachycardia.
that will be like SBB with SVT with LBBB, RBBB, or
So
WPW.
there are four reasons: SVT with LBBB, SVT with RBBB, SVT with WPW syndrome, or VT. So all are possible. Okay. So that's why in wide complex tachycardia, all these drugs we are avoiding. But that doesn't mean that we cannot give. So if it is SVT with RBBB, you can give. SVT with LBBB, you can give. SVT with only SVT with WPW syndrome, you'll have to be very careful when you are giving your beta blocker or adenosine. Why it is like that? In SVT with WPW syndrome,
normal pathway
will be blocked. So if the conduction is re-entry is through that accessory pathway, there is a high chance for increasing the problem. It can become more like patient will develop more tachycardia. That's why we are avoiding that. But that doesn't mean that even in WPWP syndrome, if the conduction is on the other way, you can still give it. Okay. So in ACLS, according to ACLS protocol, you have to only avoid this type of drugs like beta blocker or calcium channel blocker or adenosine in a suspected WPWP syndrome. Okay, but all other conditions you can give all these drugs. Where else you don't give all these drugs? Beta blockers, calcium channel blockers. Where else you cannot give? The patient is having a cardiac failure. Heart block is not there at all, because here you have a patient who is having supraventricular tachycardia. There is no heart block. But if already there is cardiac failure, when you are giving beta blocker or calcium channel blocker, patient can deteriorate. Okay, that's why we don't use that. There also amiodarone will be a better choice. So if you don't know anything, some doctors directly they go for amiodarone. If you are not aware about patient previous conditions, you can directly start amiodarone also, and that will be the last choice also. You can give it as first choice or last choice, but according to according to ACLS guidelines, they are not the first line choice. Okay. Now afterwards, should we continue heparin or warfarin this patient?
Yes.
Yes or no?
Yes.
SVT, there is no guideline to continue heparin or warfarin. Whereas atrial fibrillation, as far as you have an atrial fibrillation, even if it is controlled rate, you have to continue warfarin or heparin. Why warfarin or heparin is continued in atrial fibrillation? Why it is not continued in supraventricular tachycardia?
If there is high chance that clot can form and can.
Where is the clot formed? Left atrium. Because atrium is contracting only like this. Whereas in SVT, if you are controlling the rate, atrium is contracting properly. So there is no need to continue the like warfarin or heparin after that. Okay. Now what happens? Suppose you are not able to control the rate here. What will happen to the patient?
Patient can go into hypotension.
So one of the most important complication of any tachycardia in emergency room is the patient will soon develop hypotension and shock. That's why we are trying to reduce the heart rate. So in emergency room, first priority is always to reduce the heart rate than like controlling the rhythm. Okay, here the priority is to control the rate, not the rhythm. But if you start amiodarone, what is the advantage? What is the advantage of amiodarone other drugs?
Right.
It can control both the rhythm and rate. Is there any side effect of amiodarone? Thyroiditis. What happens to the patient if they develop thyroiditis? Initially, what will happen? Later, what will happen? What is this amiodarone-induced thyroiditis? Initially, it will have hyperthyroidism. So, thyroid gland will be inflamed and more thyroid hormone will be released. That time, again, patient can have some tachycardia, but that occurs in very minimal number of patients. Afterwards, patient will develop hypothyroidism. Initially, it will be hyperthyroidism, then it will be hypothyroidism. But very, very rarely you see all these things. So, if you want to continue on amiodarone, you can continue. Anything else you want to do in this patient? This is a young patient without any problem. He has developed supraventricular tachycardia. Should we subject this patient for some other study? EP study. You have to subject this for patient for electrophysiology study, and you have to see any foci is there which can produce all these things, and you have to rule out a WPW syndrome. All WPW syndrome produces white complex tachycardia? That is also wrong. Okay, only a few patients will have white complex tachycardia. Some patients will not have white complex tachycardia. So that also you should keep in mind. So every patient who come with SVT should be subjected for a EP study in a EP lab. Okay. Sometimes you can get an accessory pathway or a ectopic foci can be there. Okay. Anything else you want to add? So you understood how to manage. It's not very complicated. If somebody come with a tachycardia, your aim is only to control the rate. Your aim is not to control the rhythm. Okay, if there is hypotension or any other unstable features, what are the other unstable features? Huh? Altered mental status is another unstable feature. Hypotension is one unstable feature. Then
Shock, signs of
this is
cardiac
hypotension.
cardiac failure,
Huh?
chest discomfort.
Pain. Chest pain is the third unstable feature. Okay. If anything is there, don't try with all these drugs. You try to shock the patient. But if you are not so confident in giving shock, you can still try these drugs, because suppose somebody is having a BP of 100 by 60 and the patient is having supraventricular tachycardia. If you give beta blocker, what will happen? Heart rate will come down. Mostly the BP will come back to normal. Mostly. But some patients can go to hypotension. So if you are very confident in shocking the patient by DC cardioversion, should go for that. But if you are not confident, you can still try the drugs, and sometimes patient can come back to normal. Depends on your experience, clinical scenario, your setup. You can modify the ACLS guidelines. The ACLS guidelines is should be strictly followed by a MBBS doctor who is not knowing all other these variations. Okay, if you know the variations in diagnosis, you can still go for the second line or third line drug in between. Okay, thank you.